Hello, everyone, and welcome back to part 4 of our series on Introduction to Mechanical Ventilation. My name is Austin Kaiser. I'm a flight paramedic and the clinical educator with California. This presentation is called Changing the Delta, which is an introduction to bilevel respiratory support, also known as BiPAP. Today we are going to be looking at the need for pressure when it comes to our respiratory distress patients. We're going to be understanding lung volumes and the consequences of manipulating those lung volumes, and we're going to be looking at the difference between bilevel and single level respiratory support. So you walk into the room and we see that we have a 51-year-old male, has an ideal body weight of 70 kilos, history of COPD, has had an increasing history of dyspnea over the past several days, comes into the ER, we place him on a nasal end tidal, get some vital signs, and we have an end tidal CO2 of 61 and oxygen saturations of 84%, and we can see that his wife is very concerned about him. We go ahead and replace that nasal end tidal with a real end tidal, or excuse me, with a real nasal cannula and place him on 15 liters per minute. Doesn't seem to be improving his oxygen saturation. He additionally gets a non-rebreather at 15 liters per minute, and there is no change. So how much oxygen is being delivered to this patient? And we can see from the previous slide that he's getting a ton. He's getting 30 liters per minute delivered into at least his nasal passages and his trachea. So how is he not saturating well? And it's really only one reason. If you have poor oxygen saturation, despite the fact that you're giving an FiO2 of over 50%, and when you're delivering 30 liters per minute into that person's body, then they are definitely at least nearing 100% FiO2. So if they're still having poor oxygen saturations, then they either have very poor hemodynamics and they're not perfusing their lungs, so they're having a perfusion mismatch, or they have alveolar shunt. And alveolar shunt is probably the more likely scenario for many of our patients. And this is what we see in figure A down below. We see these very atelectatic alveoli. So even if we're putting a ton of flow and we are giving 100% FiO2 into this patient's lungs, that oxygen is not getting into the alveoli, so it is not going to be getting into the blood. Now, how do we solve this problem? We solve it with pressure, right? We need to not only take that flow that we're giving them, that 100% FiO2, but we need to put some pressure behind it in order to hopefully start to recruit those alveoli. And how do we do it? We do that by adding PEEP into this scenario. We start to recruit all of those alveoli, and eventually we start to see an increase in their oxygen saturation as we start to recruit more and more of those alveoli. After 30, 40, 50 minutes, we end up with this nice full recruitment, and we have very good oxygen saturation for this patient. So how do we combine PEEP and flow? We combine those two by putting our patient on CPAP, right? We have a constant or a continuous flow of oxygen at or nearing 100% FiO2 generally, and we are going to be keeping pressure in the system by adding 5 or 10 of PEEP, and we now have CPAP. Unfortunately, we're only treating the oxygenation side, right? We're not going to force this person to take way larger breaths with CPAP. So we see that even though his oxygen saturation is starting to tick up, now that we've put him on 10 of PEEP or so, he's still taking shallow breaths. We still see that his inline end tidal CO2 is 71, which is even worse than where he was when we started. So where do we go from here, short of just maybe doing a DSI and bagging him and then intubating him? Where do we go from here to try to turn this patient around and avoid an intubation? Well, in order to understand where we go from here, the first thing that we have to look at is our lung volumes. So there's a lot of vocabulary here when it comes to lung volumes, but really we're going to break it down and just focus on a few of them, and hopefully it'll clear it up a little bit for you. So the first thing is the total lung capacity. The total lung capacity is from the tippy top of what you can breathe in, that as much as you can take into your body, to as much as you can forcefully exhale out of your body. You take that volume and you add in your dead space, you add in that residual volume. That is your total lung capacity. For many of us, that is going to be at or around 80 milliliters per kilogram. So if you take somebody, a male who is 6'2", a little taller than I am, and you look at his ideal body weight, he has an ideal body weight of somewhere around 80 kilograms. So you take that 80 mLs per kilo into that 80 kilogram ideal body weight patient, and he has a total lung capacity of somewhere in the neighborhoods of 6,400 milliliters, 6,400 milliliters, or 6.4 liters that he can fit into his lungs. Just think about that for a second. We know that when we dial in a tidal volume on our patient on the ventilator, we kind of mimic what we do inherently, which we breathe anywhere from probably 5 to 7 or 5 to 8 milliliters per kilogram of our ideal body weight. So we're breathing less than 10% of our total lung capacity in each breath. So we have a ton of volume. We have a ton of space to be able to move around in that lung to kind of dial in exactly what the patient needs to make them as comfortable as possible. So the next thing that we look at is that residual volume. That's the dead space, right? So for most patients, that is about 15 milliliters per kilogram of their ideal body weight. We really can't do a whole lot with that volume because that's after you're done forcefully exhaling and you've expelled all of that expiratory reserve volume. That's the volume that's left in like your trachea and your large airways, and we really can't get rid of that. We can't do a whole lot about it. But what we can manipulate, what we can help our patients with, is we can adjust and manipulate the functional residual capacity. The functional residual capacity is really our dead space plus our expiratory reserve volume. But when you think of functional residual capacity, the only thing that should come into your mind is the word oxygenation. Typically, the FRC is somewhere in the neighborhoods of about 30 mLs per kilo for most of our patients. And for the most part, 30 mLs per kilo is more than enough for your average person to breathe room air and oxygenate well, to have oxygen saturations in the neighborhoods of 96 to 100% without any additional support. In some of our patients, we lose some of that functional residual capacity due to lung consolidation or pneumonia or atelectasis or fluid from our CHFers. There's any number of reasons why our functional residual capacity could go down, but as that decreases, so does our oxygenation or our ability to oxygenate. So if we want to improve oxygenation in our patient, we need to improve or increase their functional residual capacity. On the flip side of that coin, we have our inspiratory capacity, which you can really think of this as our ventilation side. So if the functional residual capacity equals oxygenation, then inspiratory capacity equals ventilation. Remember that in order to manipulate ventilation, we need to manipulate our minute volume. So if we increase our volumes, we are going to increase our ventilation. The last thing we're looking at is our tidal volume. Our tidal volume on this graph we can see is set at about 7 milliliters per kilogram, and that's pretty average for most patients. And if we want to change their ventilation, then we're going to need to change their tidal volume. So what changes what? If we're looking at oxygenation, and more specifically we're looking at manipulating that oxygenation, we really only should be thinking about one of two things. We should be thinking about either adjusting our PEEP or we should be thinking about adjusting our FiO2, because remember that we can put as much flow into the lungs as we want, but if we have some atelectatic alveoli and we're not perfusing those alveoli with fresh oxygen, then we're not going to be able to improve our oxygenation. So problems with your SpO2 equals PEEP and FiO2. On the flip side of that coin, how do we manipulate our ventilation in our patient? How do we manipulate that end-tidal CO2? We're really only looking at one thing. We need to manipulate their minute volume. When we have a patient on a ventilator who's intubated and being mechanically ventilated, if we have somebody who has an end-tidal CO2 of 47, the answer is very simple. We're going to typically just increase their respiratory rate in order to blow off more of that CO2, and that is perfectly fine and dandy, and that's what we're going to continue to do for the most part. However, in your conscious pressure supported patient, like your BiPAP patient, you can't just tell that patient to breathe faster, right? They're not going to do that effectively for you, and even if they do try to do it, they're not going to keep it up for very long before they get tired of it. So we can't really manipulate the respiratory rate to adjust their minute volume. We're going to need to adjust their tidal volume in order to adjust their minute volume, right? Because the CO2 concentration in your body is solely dependent on your minute volume. How much volume you're breathing per breath times the amount of times per minute you are breathing. So if we can't adjust their respiratory rate, then we can certainly just make them breathe larger volumes by increasing the inspiratory pressure support and thereby reducing their CO2 because we are increasing their minute volume. So as a reiteration, when we think of oxygenation, we are thinking about functional residual capacity. If we have your patient who is breathing or has a functional residual capacity of 30 milliliters per kilo, but they are not oxygenating well, we are going to increase their FiO2 and we're going to add some PEEP or CPAP to this equation in order to improve oxygenation. So everything below the curve is oxygenation. On the flip side of that coin, when we talk about ventilation, it's really our tidal volume plus our respiratory rate, or excuse me, our tidal volume times our respiratory rate. So if we want to change ventilation, we need to increase their tidal volume and make them breathe larger breaths in order to let them off gas even more. So we've added some inspiratory support to this patient and we've changed that tidal volume up to 12 milliliters per kilogram, and now they're going to be reducing their CO2 quite substantially. All right, so if you have SATs less than 93%, we're going to increase our PEEP and FiO2 in tandem using a PEEP scale. If our end-tidal CO2 is greater than 45, or we need to reduce their end-tidal CO2 to help them compensate for some sort of metabolic acidosis, then we are going to increase their pressure support or their IPAP. This right here is a snippet from our clinical care guidelines on web manuals, which you guys will all become very familiar with in the next coming months. And this is the initial setup of BiPAP on specifically the Ravel ventilator, but these concepts work for any type of ventilator that you're working with. So we're going to focus on adults for the purpose of this presentation, but pediatrics is no different, just a little less pressure. A little smaller deltas. So in adults, we are looking at an IPAP of 16 and an EPAP of 6. We'll talk about what that means here in a few seconds here. So they are on 16/6. We're going to change the respiratory rate to 0 from the default. It's a very important concept we'll talk about. Confirm that the mask is an improved non-vented mask. We're going to coach the patient through initiation of the mask placement, and then we're going to titrate our EPAP and our IPAP to whatever our goals are. So let's talk about these PAPs. What is an IPAP and EPAP? Very simply, what they stand for is inspiratory positive airway pressure and our indexatory positive airway pressure. And our starting values per our guidelines is 16/6. So what do those actually mean? So our IPAP, our inspiratory positive airway pressure, you can think of it as kind of like you think of your PIPs, right? So that's your total pressure in the circuit between your pressure support and your PEEP. So our starting is 16, our starting EPAP is 6, our EPAP is simply our PEEP, which would be our PEEP of 6 per the guidelines. And so we have this other number here, the difference between our IPAP and our EPAP, which is 10. And that is our delta. So that's our pressure support or our delta pressure, our driving pressure. That's the support that they are getting on inspiration that is going to increase their tidal volume and increase their ventilation. So a delta of 10 is pretty good for most of our patients, and many of our patients will not need more than that. Some would probably prefer to have a lot less than that. But it's a good starting point for a lot of our COPD patients. A good rule of thumb with the delta is that if you have somebody who's tired, you have a COPDer, they typically want a pretty high delta of about 10 or so like that because they're tired, they want that inspiratory help, but they typically don't need a very high PEEP. So 16/6 or 16/5 would probably be pretty good for most of those people. But when you get into our patients who are just having an alveolar shunting issue, like our CHF patients who just have a lot of fluid in the lungs, they don't need a high delta. They don't need a lot of pressure support. So we may be giving them a pressure support of about 5 and a PEEP of 10. And so that person would have an IPAP and EPAP of 15/10. And that might be more comfortable for them. So let's look at our patient one last time in terms of what we've now done for him. So we originally knew that his functional residual capacity was somewhere in the neighborhoods of about 30 milliliters per kilogram, but that was not quite doing it for him because we saw that his oxygen saturation was in the 80s, and so we went ahead and added some PEEP to this equation, and now we've increased his functional residual capacity to maybe 38 milliliters per kilogram, and we have thereby increased his oxygenation with some sort of CPAP or something like that. But remember that this was not a single level problem, this was a bi-level problem. He also had a ventilation problem. He had a problem with his CO2. So we needed to take that tidal volume that he had of about 7 milliliters per kilogram, and we needed to add a little pressure support to that equation. We needed to increase his tidal volume up to, say, 13 milliliters per kilogram or so, and we have thereby greatly improved his ventilation in that patient. So what's the next setting that we're looking at that I said was pretty important? We need to make sure and drop that respiratory rate, that backup apnea rate down to 0 from the default, which is 12 breaths per minute. I have a few things to say about that. The first thing is that if your patient is at risk for apnea, you probably shouldn't be doing BiPAP to begin with. That is a patient that probably needs to be intubated and placed on mechanical ventilation. Another thing is that if your patient is at risk for apnea, you probably shouldn't be leaving them alone for any period of time. You know, you put them on BiPAP and walk away for 15 minutes and you come back and they're in a cardiac arrest. That's just not something that we want to have to deal with. So if your patient is too far gone or too exhausted to try this non-invasive, then you probably should just intubate them. The other thing is that if you leave this backup apnea rate on, your I time function becomes active. And so before we talk about that I time, let's talk about the backup rate in general. So what it's designed to do is that the backup rate defaults to 12 breaths per minute. So what that means is that if you place a patient on BiPAP and you walk away and your patient becomes apneic, the Ravel is not going to just let them not breathe. It is going to essentially turn itself into a bag valve mask, and it is going to start delivering breaths to them at 12 times per minute at whatever pressure support and PEEP you have dialed in to the Revell at that time. But we shouldn't really need to use that because our patients should not be at risk for apnea, and if they are, they should just be intubated. So if we do not reduce that backup respiratory rate to 0, then that I time function is active, and we all know what the I time function defaults to in our adult patients. It is 1 second. So let's go ahead and look at this waveform right here off to the right, and we see that this patient is taking about 1.3 seconds or so to take a full breath before they decide to start exhaling. And that is pretty average for what our patients probably need. But if the I time function is the inspiratory time function is active because you forget to reduce that backup respiratory rate down to 0, then the ventilator will actually cut them off after 1 second, and it'll force them to start exhaling. And that can be very uncomfortable for our patients, and so we need to try to avoid that by making sure and dropping that default respiratory rate down to 0 so we get rid of that I time functionality while we're in BiPAP mode. As far as vented masks, very quickly, we should probably just be using our own masks most of the time, especially if we're facilitating like an interfacility transport where somebody's on BiPAP. Most hospital BiPAP masks have vents on them, and they need a ton of bias flow in order to create the seal on the mask. And the Revell doesn't compensate very well for that, and so you're just going to end up with like patient circuit alarms and low peak pressure alarms, and it's just not going to be ideal for you. And so just go ahead and use our own masks, or at the very least make sure that the mask is a non-vented mask. A quick word about mask fit. We tend to pick the incorrect size mask for our patients. We tend to do a size too big for most of our patients, just because we are used to looking at a 5'10", 200-pound male and saying, well, he wears a large t-shirt, so he probably wears a large BiPAP mask. And that's simply not the case. So if you look over at the left side of the screen, the sizing chart here, we see that the range for a medium is pretty huge, anywhere from about 3.3 up to about 4.2 inches. You're going to be a medium mask. And so that measurement is from the pupil line, which is on the bridge of the nose between your eyes, down to the bottom of your lower lip, and that is a huge area to cover as far as the sizes of our patients' faces. Anywhere from about 3.5 inches to just under 4.5 inches is going to be a medium. So that's a pretty big range that would fit a medium mask. So just understand that most of our patients are going to be a medium or even a small, and that large masks are reserved for people that have very, very large, tall faces, which is not very many of our patients. There are two concepts when it comes to comfort on BiPAP, and this really will make a big difference for you, making your patients more comfortable and more compliant on these BiPAP settings for you. So the first is a concept called flow termination. A lot of people throw that term around and probably don't know exactly what it means, but it's a fairly simple concept if you really just kind of break it down. So right here we're looking at a flow termination that's set to 10%. So if you look at that top gold bar, you see that that is the peak flow into that patient, and so that is 100% flow, the peak flow that's going into that lung. But as the lung starts to fill and fill and fill, the flow starts to decrease until eventually it would get back down to 0 as the lung was completely full. And when you have a flow termination set to 10%, what that means is that as the lung fills and fills and fills, when the flow decreases by 90%, so you only have 10% flow going into that patient, it will allow the patient to exhale. And it won't make the lung be completely full before it starts to exhale. So that is flow termination. Once it has decreased by 90%, then it'll allow them to exhale. A flow term or a flow termination of 10% is pretty darn low. The Ravel defaults to 25%, so it has to reduce the flow by 75% and get down to just 25% flow in order to allow them to exhale. With many of our patients on BiPAP, you may never get to 25% because of different leaks and things like that, and you're bouncing around in the back of the helicopter and the patient's looking from side to side, and you may be getting these little leaks, which doesn't allow the flow to get all the way down to 25%. It may plateau around 30 or 35% because of all the leakage that's going on. And so you really want to just increase that before you ever put your patient on the ventilator, just to make sure that they are not being trapped in an inhalation cycle and that they be allowed to exhale when they would like to. So on the Ravel, you can increase it to 40%. That's the maximum for that ventilator. Different ventilators may allow you to increase it up to upwards of even 50% to allow them to exhale earlier, or at least allow them to exhale when they would like to. So that's flow termination. So we're going to increase the flow termination to at least 40% before we ever put the patient on the mask. The last concept that we talk about is rise time, and this is something that gives a lot of people confusion, but hopefully this graph will help to kind of make things a little clearer. So rise time is active anytime you have a pressure-driven breath. So if you have somebody on assist control pressure, or you have somebody on SIMV pressure, or if you have somebody on BiPAP, you have this rise time function. And what it is it is the amount of time that it takes for the lung to reach about 90% full. And so if you have somebody who has an inspiratory time of about 1 second, as an example, we can see that on this graph, if that inspiratory time is 1 second, then the rise time, the amount of time it takes for the lung to get pretty much full, is about 0.2 seconds or 0.3 seconds in this example. So that person would have a rise time of about 3, because in 0.3 seconds they have about 90% lung filling. And really, I would say that it isn't necessarily 90% lung filling, but it's 90% of the peak flow into the patient, 90% of the peak pressure into the patient within that 0.2 seconds. So it's essentially how fast they are driving. How fast it feels like they've got their face out of the car, and how fast it feels like the car is going. That's the rise time. We can manipulate this essentially for patient comfort. I wouldn't necessarily change it before I put it on the patient's face. I would like to let the patient really guide me on what they want. If you put the mask on and it looks like every time there's an inhalation cycle, and their cheeks are puffing out because they're kind of resisting how quickly the air is coming into the mask, and they don't want the air that quickly, then that patient feels like they've got their head out of a car at 200 miles an hour, and it makes them feel uncomfortable. So we need to elongate that rise time out to maybe 4 or 5 or even 6, like 0.5 or 0.6 seconds. To make them more comfortable. And I know that just anecdotally from when I put myself on BiPAP, when I just practice doing BiPAP and making myself comfortable, I need a rise time of about 5 in order to make myself comfortable. If I reduce it down to 2, then it is very uncomfortable for me, and I feel like I'm getting blasted in the face with this pressure. If somebody's pretty short of breath, though, they may want exactly that. They may want that rise time of 2. They might want that full pressure within, or that full filling within about 0.2 seconds. And then they'll hold that pressure in there, they'll hold that breath in there for another 0.8 or 0.9 seconds, and then they'll let it go and start exhaling. So really, you're just going to need to let your patient guide you. If they feel like they're not getting the air fast enough, then you're going to shorten that rise time. If you feel like they're getting blasted in the face and with like a hurricane, and they don't want the air that fast, then we're going to go ahead and elongate out that rise time. So the 7 steps to being very successful at BiPAP, we're going to choose the correct mask size. Remember not to go too big. We're going to set up our initial IPAP and EPAP of 16/6. We're going to reduce that backup respiratory rate to 0 instead of leaving it at the default of 12. We're going to increase that flow termination up to 40%. And then once we get the mask on the patient, we're going to adjust that rise time to really tailor to their comfort. Do they feel like they're getting hit in the face with hurricane force winds, or do they want the air super fast and a little bit faster than what the ventilator might default to? And then after that, we're going to adjust our pressure support and then our PEEP and FiO2 in order to attain our end-tidal CO2 and our SpO2 goals. All right, guys, so thank you for hanging out on part 4 of Introduction to Mechanical Ventilation. If you have any questions or comments about this presentation, make sure and email me at akaiser@phiairmedical.com, and I look forward to seeing you guys in the future.